Okay, well, congratulations to all of you for making it this far along in the course. I know it's an intense board review course, and no such course would be complete, certainly without cardiology. And that's because cardiovascular disease is the largest section, single largest section in the exam. According to this ABIM blueprint, it's 14% of the exam, which exceeds all the other topics. And that's appropriate, given that cardiovascular disease is the leading cause of death, not only in the United States, but also worldwide now. So no matter what you go on to do in medicine, you're going to need to know a bit of cardiology. So here's the breakdown of the topics within cardiovascular disease according to the ABIM blueprint. And you have these in your syllabus. What you need to know is that we're going to touch upon all of these topics over the next 2 days. So here's our review outline. And if you're looking for some extra references, I recommend the American College of Cardiology website at acc.org. And you go to their website, and the very first header tab on the home page here is Guidelines. Click on that tab, and all of the American College of Cardiology, American Heart Association guidelines are available for free to the public. So you can look up all of these guidelines, and these ones listed here in particular are those that are relevant to internal medicine boards. And I will be highlighting the most important recommendations from each of these for you. Okay, so let's go ahead with part 1, diagnostic studies. And one of the most basic diagnostic studies you can get other than the ECG is a plain chest X-ray. So on our first chest X-ray here, this is a pretty classic example of severe heart failure. It has all the characteristics: pulmonary vascular redistribution, cephalization of vessels here at the top. You can clearly see that the heart is very enlarged, so cardiomegaly is present. And out here, there are curly B lines, these horizontal thin lines out in the periphery of the lung. And they're perpendicular to the pleural surface. They represent thickened interlobular septa, which is common in pulmonary edema, which in turn is common in heart failure. There's also perivascular cuffing, these little circles that you can see here, and that's also classic in pulmonary edema. This is the water bottle heart that you would see in a severe pericardial effusion. And on this chest X-ray, we see an outline of calcium in the pericardium. You can see it both on the PA and on the lateral, just outlining the entire pericardium there at the base of the heart. And here's how it would appear on CT scan, and that's classic for constrictive pericarditis, which we'll go into in great detail later. For aortic coarctation, this is a pretty classic chest X-ray. First of all, you lose this aortic knob, and then look here at the inferior margins of the ribs. This is pathognomonic for aortic coarctation, and that is rib notching. So what happens in coarctation is, in long-standing cases, due to the tortuous and dilated vessels beyond the coarctation, they erode the inferior surfaces of the ribs, and so you get this rib notching. So this is an X-ray that just shows an AV sequential pacemaker, or also known as a dual chamber pacemaker. And you can see the device here in the left pectoral region, and 2 leads, importantly, the right atrial lead and the right ventricular lead. Now, if this were an ICD, the main difference would be the box here is bigger. It looks more like a big square than this more oval device. That's a single chamber pacemaker, just to show you the difference. There's only 1 lead, and when there is only 1 lead, it's at the apex of the right ventricle. You can see it here. The right ventricle is anterior in the lateral chest X-ray, just behind the sternum, and you can see that RV lead is placed nicely there in the RV apex. So let's move on to echocardiography, which is a big staple of cardiology. Now, there aren't any echo images on the internal medicine boards, but case studies will refer to echo findings. So if, for instance, as an internist, you're presented with an echo report, you need to know what the findings mean. Why do we use echo? It has a lot of great uses in cardiology. Of course, cardiac function like ejection fraction, chamber size, wall thickness. We look at the heart valves. It's great for congenital disease. We can get a good look at the aortic root. You can also estimate pulmonary pressures through Doppler, pericardial diseases and cardiac masses. And with TEE, which we'll talk about a little bit later, you can pick up descending aortic dissection. And in fact, TEE is the first-line study for an aortic dissection. And then hypertrophic cardiomyopathy, we use it for that. So here's our first question. A temporary transvenous pacemaker was placed in a patient in the CCU. Minutes later, he developed hypotension and elevated neck veins, but the lung fields remained clear. So what would you expect an echocardiogram to show? A, severe left ventricular dysfunction. B, acute aortic regurgitation. C, acute mitral regurg. D, hypertrophic cardiomyopathy. Or E, a large pericardial effusion. Excellent. The vast majority of you got that right. You would expect a large pericardial effusion, and that's because, if you remember from the chest x-ray I showed you, where the RV lead is placed, it's at the apex of the right ventricle. And if for some reason they perforate the right ventricle, you'll end with a hemopericardium and a cardiac tamponade. So you expect to see that large pericardial effusion. And that is what a large pericardial effusion looks like. You can't tell on ultrasound alone whether or not this is blood or just other fluid. It's just a black space. But the pericardium really should have very little fluid in it at all. So this is a huge pericardial effusion. Other common findings you might be given on the exam are findings of hypertrophic cardiomyopathy, AS and AR, MR and MS, and we'll talk about those in those respective studies. So basic findings for hypertrophic cardiomyopathy include that thickened septum. That's key. And that septum can obstruct the left ventricular outflow tract. The key to the LVH that appears in hypertrophic cardiomyopathy is that it's asymmetric. Okay, so this is what it would look like on echo. Again, you're not expected to interpret this image, but just so you have a mental image of it, this is the interventricular septum, and you can see this knob coming out into the left ventricular outflow tract, jutting into the left ventricle. That's hypertrophic cardiomyopathy. That's asymmetric left ventricular hypertrophy here with the septum. Okay, moving on to aortic stenosis. You might be told that the aortic leaflets are thickened and calcified, or that there's a bicuspid valve, which in and of itself is a predisposition to aortic stenosis. You would expect to see reduced leaflet excursion and mobility and a severely reduced valve area. So that's what aortic stenosis looks like on echo. This is a transthoracic echo, and this is a tricuspid valve, but it's got a lot of calcium on it. See, all of this white here in the middle of the valve is calcium, and it's barely opening, so it's got a pretty reduced valve area when it does open. Same thing with mitral stenosis. You expect to see findings of thickened and calcified leaflets and reduced leaflet excursion and a severely reduced valve area. So this is a TEE of mitral stenosis. This is the mitral valve, and it's barely opening, and it's got a lot of calcium in it as well. These leaflets should be thin, but they're thickened, and they've got a lot of white in it, and white on echo is calcium. Okay. So moving on to aortic regurgitation. You've got the regurgitant jet into the left ventricle, and often there will be some description of a damaged valve or a vegetation as a cause of the regurgitation. And this is what aortic regurgitation, severe torrential aortic regurgitation, looks like on transthoracic echo. This is the aortic valve, and all of this backflow into the left ventricle is regurgitation. On mitral regurgitation, same thing. You'll have a description of a regurgitant jet into the left atrium. The valve has been damaged in some way or there's a vegetation. There may be tethered leaflets or torn chordae, especially in a patient who's had a prior MI, because ischemic mitral regurgitation is a common cause of mitral regurg. So again, we're in TEE mode here. So in TEE, this is the mitral valve, the bileaflet valve, with regurgitation back into the left atrium. Okay, next question. A 55-year-old woman with a history of bicuspid aortic valve, so there's your first clue, presents with worsening dyspnea. A transthoracic echo shows calcification of the valve and reduced valve area. Which of the following is most likely indicated? A, carotid endarterectomy, B, aortic valve surgery, C, mitral valve surgery, D, septal reduction therapy, or E, observe and repeat the echo in 6 months. Excellent. The vast majority of you got this right. The correct answer is B, aortic valve surgery. And this is just an example of how echo findings might be presented to you on the boards in the stem of a question. And you're supposed to use those findings to guide your decision making. We'll go over this further in the section on valve disease, but for now, take away the key point that with any aortic or mitral valve disease with symptoms, that patient needs to get a surgical procedure for repair or replacement. So symptomatic valve disease gets a procedure. Next question. A 75-year-old male with a history of prior MI presents with worsening dyspnea and fatigue. On exam, you detect a 2 out of 6 holosystolic murmur best heard at the apex. So what should you order next? A, an exercise treadmill test. B, a transthoracic echo. C, a transesophageal echo. D, ankle brachial index. Or E, a MUGA scan. Good. The correct answer is a transthoracic echocardiogram, and most of you got that right. This is another example of how echo findings would show up on the boards, or how echocardiography itself would show up, and that's knowing when and how to order it. So for this patient, you're investigating a pathologic murmur. 2 out of 6 holosystolic murmur is not a normal finding. And the first line diagnostic test for a murmur like that is a transthoracic echo. Not a TEE, which is reserved primarily for endocarditis and cardiac shunts, like a PFO or ASD. For basic murmur investigation, and you do suspect ischemic MR in this case, by the way, for that you get a TTE. And then as for the other answers, an exercise treadmill test is for cardiac risk stratification when you suspect ongoing ischemia, not for a murmur evaluation. We'll go over the treadmill test in great detail later. And the ABI is for evaluation of peripheral artery disease. We'll go over that later as well. The MUGA scan gives you a very accurate assessment of ejection fraction, and it only gives you ejection fraction. It doesn't look at valves, and that's mainly for patients who are undergoing chemotherapy where you need that accuracy. Okay, moving on to transesophageal echo, TEE. We use that for endocarditis evaluation for acute MR or AR because it can be done right there at the bedside in a decompensated patient. It's good for aortic dissection, and of course we use it prior to cardioversion for AFib or flutter, looking for any thrombus. So here's our next question. A 65-year-old woman with diabetes and poorly controlled hypertension presents with severe central chest pain. Chest x-ray shows widening of the mediastinum, and she tells you that the pain radiates down her back in a ripping or stabbing sensation. So what do you order next? Anticoagulation with heparin, emergency coronary angiography, transesophageal echo, barium swallow, or fibrinolytic therapy? Okay, great. You guys are knocking this out of the ballpark. You should, from the clinical description in the STEM, be suspecting aortic dissection in this patient. So from what I just told you about TEE indications of the options presented here, transesophageal echo is what you want to get. You could kill the patient if you anticoagulated somebody with a dissection. Same thing if you gave them lytics. We're not thinking of ACS here, acute coronary syndrome, so we're not going to go to emergent cath. The stem of the question really points you in the direction of a dissection, and so you want that transesophageal echo. Okay, let's move on to stress testing. So the indications for stress testing is when you suspect ischemic heart disease or when you want to risk stratify, especially in a patient who's already had an MI. You can also assess the effectiveness of your therapy, and you can establish an exercise regimen for your patient with an exercise treadmill test. So let's talk about typical angina and what the features of typical angina are. There are three key features for the presentation of angina to be called typical angina. One is that it occurs or worsens with exertion. Two is that it's relieved by rest or nitroglycerin. And three is that it has a typical location in the anterior chest, neck, shoulders, jaw, or arms. So if it fits the description and the location and the precipitating and relieving factors are just right, both of those have to be right for you to have what's called typical angina. Otherwise, if maybe the location is off or it's not relieved by rest, one of those factors is off, you call that atypical chest pain. And then non-cardiac chest pain has none of those three features that I just mentioned. Okay, so that helps you a little bit starting to put patients into a pretest probability range in terms of what is their pretest probability of coronary artery disease. So it changes depending on whether or not you think they have non-cardiac chest pain, atypical chest pain, or typical angina. It changes by gender, and it changes by age. What you want to focus on are the numbers in red here. They may not be in red on your syllabus, but so you'll want to highlight them. These numbers in red are where the pretest probability is right there in the intermediate range, and those are the patients who are most going to benefit from an exercise treadmill study. This is not a table for nuclear imaging. This is specifically for exercise treadmill, okay, for risk stratification with that. So take a look, for instance, at the female patient who is in the age range of 30 to 39, and she has atypical chest pain. Her pretest probability of having coronary artery disease is really only 12%. And so if you get an exercise treadmill test and it's positive, it's likely to be a false positive. So that doesn't help you as much. On the other hand, in a male patient who is in the age range of 60 to 69 and presents with typical angina, his pretest probability of having coronary disease is 94%. So if your exercise treadmill test is negative, you wouldn't believe it. It's going to be a false negative. So it wouldn't help you there either. It's really just in this intermediate range where the exercise treadmill test is most helpful. And that goes back to Bayes' theorem, stating that the accuracy of any test depends on the prevalence of the disease in the population studied. And that highest accuracy comes right there in the 50% range. Okay, so that's just as I had mentioned. But why use exercise at all, even in the patients who don't fit into that intermediate probability range? Well, it mimics normal patient activity, and it's inexpensive. And most importantly, it gives additional prognostic information about somebody's cardiovascular fitness and their functional capacity. So even if you don't expect to get all of your information from the treadmill test, if the patient can exercise, go ahead and do it, and you can add other imaging studies if you need them. So this is what an exercise treadmill test would look like in terms of ECG changes. This is a normal baseline ECG going into the test. And this is during exercise. And a positive test is defined by at least 1 millimeter of horizontal or downsloping ST depression. And here is horizontal ST depression of at least 1 millimeter on this study, so that's a positive exercise treadmill test. Also positive is any arrhythmia, ventricular arrhythmia like VTAC or ST elevation of at least 1 millimeter. That's also a positive test. Now, we know that many patients can't exercise, and the specificity of an exercise treadmill test alone as the only test declines as the baseline ECG kind of gets uglier, roughly in this order: nonspecific ST changes, digoxin therapy, right bundle, left ventricular hypertrophy, and WPW, left bundle or paced rhythm. That's where if you have these, left ventricular hypertrophy or left bundle, on your baseline ECG, you know you're going to get another imaging test, in addition to exercise if they can exercise, because the ECG will just be uninterpretable during exercise. Okay, so if a patient can exercise, do everything you can to get the exercise portion of the test, and then let the baseline ECG guide you as to whether to add imaging, or let their pretest probability guide you. And this is just an algorithm that you can look at, emphasizing that point about the resting ECG being normal. If it's not, you know you're going to have to get perfusion imaging, usually in the form of nuclear imaging. If it's yes, go on to the test. And this is assuming that you've already done your pretest probability and you know which patients will benefit from an exercise treadmill test. Now, if they're not able to exercise and you want to get a stress test, then you have to go the pharmacologic route. And you ask yourself about contraindications to the different pharmacologic agents. So does the patient have a contraindication to a vasodilator, which would be bronchospasm, or to dobutamine, which would be valvular dysfunction or severe hypertension, some AV blocks? If no to any of those, then they can get vasodilator or dobutamine nuclear imaging, or you can get a dobutamine echo. But if they have a contraindication to a vasodilator, and particularly for your purposes, these would be patients with asthma or severe active COPD, they could not get a vasodilator like adenosine. If they have that contraindication, then you go down this route to dobutamine, and you look at and see whether or not they have a contraindication to dobutamine, or if they have poor echo windows, and you decide what dobutamine study to get. If they have contraindications to all of those, then you're looking at another test entirely, like CT angiography or even cardiac cath. So let's look at this question. A patient with risk factors for CAD presents with chest pain, and an MI has been ruled out. The baseline ECG shows LVH, and the patient is able to exercise. So which stress test should be ordered? A regular exercise treadmill test alone, B, an exercise treadmill test with nuclear perfusion imaging, C, a pharmacologic stress test with nuclear imaging, D, an ST segment sensitive Holter monitor, or E, cardiac cath. The majority of you all got this right, but we had a little bit of a split here with the regular exercise treadmill test. The correct answer is B, an exercise stress test with nuclear perfusion imaging. Remember, the patient had LVH on the baseline ECG, and that's going to make the ECG so uninterpretable during exercise that you're going to have to add imaging. So that's the main reason you're going to get the nuclear perfusion imaging. Now, why do you get exercise instead of pharmacologic? Well, the patient can exercise. So if they can, you always get that part. An ST segment sensitive Holter monitor is kind of non-existent. I made that up. And cardiac cath is not indicated yet. This patient ruled out for MI. Okay, next question. A patient with severe claudication and asthma presents for risk stratification, and the baseline ECG shows LVH. Now, what stress test should you order? A regular exercise stress test, an exercise test with nuclear perfusion imaging, an adenosine stress test with nuclear perfusion imaging, a dobutamine stress echo, or cardiac cath. Okay, the majority of you still got this right, but this is a little more difficult because you're having to decide between pharmacologic agents. The correct answer is a dobutamine stress echo. This is a patient who has severe claudication, so he can't exercise. He also has asthma, so you have to steer away from adenosine, and that leaves you with the dobutamine stress echo. And just once again, cardiac cath is not a stress test. Okay, pharmacologic stress testing, we know it's necessary if the patient can't exercise. The vasodilators that are used are adenosine, dipyridamole, and regadenoson. And then there's dobutamine. The vasodilator stress imaging is particularly useful in patients with left bundle or paced rhythms. Dobutamine doesn't do as well with those patients. It causes some imaging artifacts. And then with myocardial perfusion imaging, the tracers that are typically used are thallium or more commonly 99M technetium, and they distribute in the heart where there is adequate blood flow. So uptake is decreased during stress in the ischemic zones, and you can see that on the nuclear images. You can also measure LV systolic function. You get an ejection fraction at rest and with stress with myocardial perfusion imaging, and you can evaluate myocardial viability, especially with PET scan. So this is an example of myocardial perfusion imaging with a nuclear radiotracer. You are not expected to interpret these images for the IM boards. I just want to show you what's going on here so that you have an understanding. What you're looking for is a perfusion defect. So if you think of this as a donut, you look for a bite out of the donut. And whether or not that defect is present on stress or rest or both. If it's present on stress, as it is here, but not at rest, it fills in nicely at rest, that's a reversible defect, and it means that's ischemia. There's ischemia in that zone. If it's present on both rest and stress, that's a prior infarction. And then if you really wanted to know something about viability, you might want to get a PET scan or an MRI, which we'll talk about in a moment. Okay, looking at stress echo for a moment. It is less expensive and more specific than nuclear imaging, but it's less sensitive, and it really depends on local expertise. In patients who have left bundle branch block, just like with dobutamine, the images are not as good with stress echo if they have an underlying left bundle, so we don't like to use it there. All right, let's look at cardiac CT and MR, which I've mentioned a bit to you. Now, first of all, there can be some confusion between non-contrast CT for coronary artery calcium scoring versus CT angio, or CTA. The non-contrast CT detects coronary calcification. It has a low radiation dose, and it does not use contrast. And we use it just primarily for coronary artery calcium scoring. The CTA does give you a greater radiation dose, a moderate dose of radiation, and you must use contrast. And we use that in evaluation of chest pain and looking at anatomy because it will outline the coronary vessels for us. Two totally different tests. The drawbacks of the CT angiogram are the higher radiation dose, although that is coming down a bit with newer technology. It does still require iodinated contrast, and you need to have a low heart rate, preferably less than 60 to get the best images. So often patients have to have a beta blocker to get this study done, and they have to be able to hold their breath for 15 seconds. Now, the non-contrast CT, that's mainly for the coronary calcium score, and if you have a calcium score greater than 100, that does indicate an increased risk of cardiac events, so that's kind of the first cutoff there. If there is zero coronary calcium, though, that has great negative predictive value, predictive of a very low risk of a cardiac event. So if you really want to break down the calcium score, going from 0 to 400 or higher, at 0, that implies no identifiable plaque and a very low risk of coronary disease over the next 10 years. At 100 is your threshold for saying there's, okay, definite, at least moderate plaque, so you would classify that as mild CAD, someone who is at risk, someone who has CAD. At 400 or higher, that indicates extensive plaque, and there's a high likelihood of at least one significant coronary narrowing, and the odds of having an ACS event are greater than 10 to 1 over the next 10 years. So that's a high-risk patient. Now, I will make a point here, just because they have a coronary score that's high doesn't mean you send them to cath, especially if they're not having symptoms of ischemia. It just means you need to treat all of their risk factors very aggressively, and if they do present with some symptoms, you take that very seriously. This is how the right coronary artery appears on a 3D reconstruction from a CTA. So you can see it's a nice outline of the aorta and the coronary coming off there. And this is just more of the reconstruction of the right coronary artery and its course, and you can see all of this with CTA. For coronary calcification, I mentioned that to you before in the pericardium, with coronary CT, you can actually see it within the coronary arteries. So this is extensive coronary calcification in the LAD and one of its branches, probably the diagonal here. And that patient would probably have a pretty high coronary calcium score, but you'd have to get the whole picture. Now moving on to cardiac MRI. It's great for looking at LV function. It's very accurate in giving you left ventricular ejection fraction and right ventricular ejection fraction. It can look at the valves, and it's good for tissue characterization of the infiltrative cardiomyopathies like hemochromatosis, sarcoidosis, amyloidosis. It's good for looking at masses, and we use it a lot for myocardial viability. So here is an example of how you would use cardiac MR for looking at myocardial viability. This is known as gadolinium hyperenhancement. And so this white area all through here represents non-viable inferior myocardium. So if somebody had an RCA that was 100% occluded, we know that the right coronary artery supplies the inferior wall, and you had this MRI, you wouldn't recommend to them getting it revascularized because it's not viable. And this is an example of myocardial viability by PET. This is just to remind you that PET scan is particularly useful for analyzing myocardial viability. And here's a question on really how viability is used. So a 65-year-old male with a history of MI in the past month and congestive heart failure with an EF of 30% presents with a PET scan that shows viability in the anterior wall. He asks you if he should take his cardiologist's advice. And you say, yes, of course he should follow his cardiologist's advice, which is to A, undergo coronary revascularization to the anterior wall, B, wear a 48-hour Holter monitor, C, get an ICD before doing anything else, D, get a pacemaker, or E, have a TEE performed. Okay, great. The majority of you got this correct. The correct answer is A, undergo coronary revascularization to the anterior wall. Again, this is an example of how viability is used in clinical decision making. If an area is viable, which his anterior wall was on PET scan, it should be revascularized because that improves both symptoms and outcomes. A Holter monitor is really for evaluation of palpitations and arrhythmias and doesn't apply here. Definitely don't put in an ICD before all revascularization options have been explored. We'll talk about that more later too. But if he has viable myocardium, his EF will likely improve after revascularization, and he might not need an ICD at all. So you've got to explore that first. As far as a pacemaker, there's nothing given in the stem of the question that makes you think he needs a pacemaker. And you don't need a TEE because you already have all of the diagnostic imaging information you need at this point. Let's go on to cardiac cath now. So with left heart cath, it can be an emergency procedure, so all contraindications are relative. The mortality is very low, less than 0.1% with left heart cath, and you can also get a ventriculogram that gives you an ejection fraction, and aortography can also be performed at the same time as coronary angiograms. The most common indication, of course, is for coronary artery disease. And the radial approach, rather than the femoral approach, has less morbidity associated with it. So possible complications from cath are, if it's a femoral approach, retroperitoneal hemorrhage. That's a very important one to know. And then with both approaches, you could have coronary dissection, cardiac tamponade, or cholesterol embolism and livedo reticularis. So here's our next question. A patient has coronary angiography from the femoral approach, and immediately after the procedure, she develops sinus tach and severe hypotension. Her ECG is otherwise normal, but a stat CBC shows a hemoglobin of 7. What is the most likely diagnosis? Is it A, myocardial ischemia, B, retroperitoneal hemorrhage, C, cardiac tamponade, D, pulmonary embolism, or E, tension pneumo? Excellent. Almost all of you got this correct. The answer is retroperitoneal hemorrhage. You notice that this was done from the femoral approach, and this is a possible complication of that. If someone becomes shocky and anemic right after a cath with a femoral stick, you have to think of this. Now, you can also have cardiac tamponade after a cath, but that wouldn't be associated with such a dramatic drop in hemoglobin acutely because you just can't put that much blood in the pericardium. But you can hide it in the retroperitoneum, and I think you all got that. In terms of PE and tension pneumo, those are not common complications of cardiac cath at all. And those conditions wouldn't cause acute anemia either. So retroperitoneal hemorrhage, you got that. Next question. A 75-year-old woman had a coronary angiogram 3 weeks ago. Over the past week, she has noted discoloration and pain in the left foot. Her lab data now shows a serum creatinine of 4.5, and this is what her foot looks like. So what's responsible for her renal failure? Is it A, underlying interstitial kidney disease, B, iodinated contrast nephropathy, C, atherosclerosis of the renal arteries, D, an allergic reaction to iodinated contrast, or atherosclerotic embolism to the kidneys and systemically at the time of cath? Good. 95% of you got that one too. The answer is E, atherosclerotic embolization. That's the only thing that can explain her foot findings. And those findings in that photo are classic for cholesterol embolism. It's a rare but possible complication of cath because the catheter goes through the aorta and that can flick off emboli to the rest of the system. Okay, right heart catheterization, also known as PA cath. This is where we get our pressures, our hemodynamic information. So let's start with the pulmonary capillary wedge pressure. So the wedge pressure is a dampened form of the left atrial pressure, which in turn represents the left ventricular and diastolic pressure. So it gives you an idea of how the left ventricle ultimately is functioning. Normal wedge is less than 12, and it increases with left-sided processes. Left ventricular hypertrophy, LV failure, left-sided valvular disease like mitral stenosis, mitral regurg, aortic regurg. Tamponade and constrictive pericarditis will also increase the wedge. Know that acute increases in wedge pressure cause more symptoms at lower pressures than chronically elevated levels because with chronic elevations, people can compensate. So normally, pressure is less than 12. When it gets greater than 12, you'll see some mild dyspnea on exertion. At 15 to 20, there's frank dyspnea on exertion, and 25 to 35, there's dyspnea at rest. When the wedge is over 35 in most patients, there's pulmonary edema. So what about the right-sided heart pressures? Well, the normal right atrial pressure is less than 7, and jugular venous distension occurs when it goes higher than that. Increased RA pressures are usually indicative of right heart failure, and this is classic in right ventricular infarction. You'll see these pressures elevated. The right ventricular systolic pressure will also be elevated in right heart failure. Normally, it's less than 30. So let's go through some examples of right heart pressures on PA cath. Example 1 is what is normal. So that's what you want to keep in your mind. Right atrial pressure in the range of 0 to 5. PA pressure, 13 to 28 systolic over 3 to 13 diastolic. Wedge pressure, 3 to 11, and of course, normal blood pressure. So let's look now at example 2. Here, the right atrial pressure is elevated, as are the PA and wedge, and if you'll notice, the diastolic pressures are equalized. Okay, RA pressure is 18, PA pressure is 18, wedge pressure is 17. This is called equalization of diastolic pressures, and there's systemic hypotension. So that is a combination that's consistent with cardiac tamponade. The two conditions that cause tamponade and equalization of diastolic pressures are tamponade and constrictive pericarditis. And in the section on pericardial diseases tomorrow, we'll go over how to differentiate between those two. But when you see equalization of pressures, think of those two conditions. In example 3, we've got an elevated RA pressure at 15. The PA pressure is normal, 21/11. The wedge pressure is normal at 10, but the patient is hypotensive, 70/50. So we're thinking of a right-sided process here. The RA is much greater than the wedge, but the patient's hypotensive. So you're thinking RV failure, and if this occurs in the setting of an inferior MI, this represents RV infarction. So that's example 3. Now looking at example 4, the RA pressure is very elevated at 18. The PA pressure is moderately elevated, 40/30. The wedge pressure is quite high at 30, and there's systemic hypotension. So what can cause that? So the RA pressure is high, but the wedge is extremely elevated. You know there's something that's got to be going on in the left heart too. And this patient is hypotensive. So those are hemodynamics that represent cardiogenic shock, usually from an MI, and you'd expect cardiac output, which is normally 5 to 6 liters a minute. In this case, you'd expect it to be low. So you go back and look at that again. Really, all your right heart pressure, all of your pressures are elevated. And in the case of systemic hypotension, you have to think of cardiogenic shock. Now, example 5 is a situation in which all of your pressures are also elevated, but there's a difference. For one thing, the patient's not hypotensive systemically. And for another thing, the PA pressure, the systolic pressure, is extremely elevated. So something's causing the PA pressure in particular to be very high. The pulmonary systolic pressure is 90 and the wedge is 30. So what can cause both a left-sided process and pulmonary hypertension, especially in particular? That's mitral stenosis. Okay, everything backs up. So this is a patient who has chronic mitral stenosis because they're not hypotensive. So they're walking around with this, but it's been going on so long that things have backed up from the left ventricle to the left atrium all the way into the pulmonary arteries. And pulmonary hypertension is common with chronic severe mitral stenosis. Okay, example 6. The RA pressure is elevated, 18. The PA pressure is extremely elevated, 90/32. But the wedge is normal, and the blood pressure is normal. So something is isolated to the right heart, and something is making the PA pressure very high. That's pulmonary hypertension. That's probably primary pulmonary hypertension isolated to the pulmonary arteries and not coming from the left heart because wedge pressure is normal. Okay, in terms of another study that can be done, the endomyocardial biopsy, switching gears here for a moment, that's used to evaluate the etiology of cardiomyopathy or myocarditis. It's also useful if you suspect doxorubicin toxicity, and especially for transplanted hearts. That's where we evaluate possible rejection. Know that a negative endomyocardial biopsy in sarcoidosis doesn't rule out myocardial sarcoidosis. And you don't do a biopsy if you suspect alcoholic cardiomyopathy. You get that diagnosis from history. So here's our next question. A 35-year-old woman presents with a history of a substernal